been downtown to listen to a coroner's case, so it ties in fairly well with her talk. For those people who work in the communities, there's not a huge amount of specialist neurosurgical services outside of major metropolitan centres, so this often falls upon the realm of the general surgeon and other acute care surgeons to look after. So I'm grateful for your expertise.
And I'd just like to start by acknowledging the work of Campbell Tingate, who's done a lot of the literature review and some of the data analysis for this. So when I was invited to provide this talk, I initially hesitated because I'm very overcommitted. And then I thought, no, actually, I feel like there's an epidemic of 69-year-old men who've fallen off ladders occupying my ward. And so I should actually make sure that there's some evidence behind the treatment we provide and behind some of the rules of thumb we use to guide treatment. Things like my rules of thumb are things like if you're on aspirin and you hit the deck, you're stuffed. And if you're over 75 and you need a craniotomy, you're going to die. And so I thought maybe I should check whether they're actually valid management tools to use. So the first thing that surprised me is there is not actually an epidemic of 69-year-old men occupying the ward. In fact, apart from the peak of silly young men, the probability of head injury is fairly stable across all the decades. If you correct this for the population numbers, it flattens the graph out even further. And even if you apply the slightly increased length of stay that the elderly patients have, it's still a pretty flat graph. So elderly patients are not that much more likely to get head injuries than their younger friends. The next question I had, and thank you very much to Olivia Zeng and the Royal Brisbane Hospital Trauma Database for provision of this data. Why do they get head injuries? And as you might expect, in younger patients, the overwhelming majority of head injuries are from traffic accidents. And I've actually included in these pedestrians hit by cars and push bike accidents, with a much smaller proportion of falls, and these are mostly falls from height, so people falling off ladders and balconies. Whereas as you get older, there's an increase in the proportion of falls, and also the height people are falling from gets smaller, so they're no longer falling off balconies, they're now falling off chairs and out of beds and from standing height. This other group, in the older patients, surprisingly, was predominantly falls from horses. The younger patients still fall off horses, but it's more or less split between assaults and sporting injuries. And this data is very similar to data from around the world. So this is a German trauma database series. So I'm interested to note that the proportion of traffic injuries in the older patients is much lower in Europe, and maybe that reflects Australia's dependence on the car. And the falls from low height becomes by far the majority of head injuries in this group. Once people have fallen, what sort of injuries are they getting? And is it that the elderly are being more severely injured? Is that why I feel that there's such a burden? And it is true that there's a change in the nature of the pathophysiology of the injuries in the elderly. So in young patients, there's a roughly equal number of patients who get subdural hematomas and extradural hematomas. But as you get older, your dura gets more and more stuck onto your skull, and the probability of getting an extradural hematoma falls, and consequently the probability of a subdural hematoma rises. But it rises even faster, and so by the time you get over 60, you've got a significantly higher probability of having an intracranial hemorrhage than you would have had when you were younger, and even more so when you take into consideration the type of fall. So a young person who falls from a standing height probably won't get a hematoma, whereas an older patient will. And for an assortment of reasons, including how robust their tissues are, the fact that their brains are more likely to be atrophied and have room to shake, and the fact they're more likely to be on an antithrombotic agent. The German trauma database shows similar results, so the probability of an extradural hematoma continues to fall as you get older, the probability of a subdural rises, and also the probabilities of diffuse parenchymal injuries rise. So you're more likely to get a traumatic subarachnoid or an intracerebral hematoma from your head injury as you age. And that has important implications for the outcomes. And I think this is why I feel that there's an epidemic. It's because these patients are emotionally heavy. There's a really high chance they'll die. It's traumatic and memorable and distressing for everybody. So once you get over 60, there's an increasing probability of mortality. Again, this is the Royal Brisbane Hospital Trauma Database, and it includes all head injuries. So mixed into this are the trivial little spots of blood in people who live alone and are watched overnight, and the catastrophes who are taken to intensive care. But by the time you get to 90 at the Royal Brisbane, there's a really good chance you're going to die from your head injury. And I looked at this and I thought, this is catastrophic, we're doing a terrible job. But if you look around the world, you find similar results. So these are patients admitted to 3 neurosurgical intensive cares in Italy. And that becomes a selected group now because, as they say in the paper, the patients who are really well didn't get transferred to the neurosurgical intensive care. They stayed in their regional hospitals. And the patients who are really bad didn't get transferred either. So these are a group of patients with a significant enough head injury that people are worried about it, but good enough protoplasm that people think it's worth working really hard to try and save them. And even in that group, there's a significant mortality. One of the things I find interesting about this is that in the older patient, surviving ICU is not enough. If you're 20 and you make it out of ICU after your head injury, there's a very good chance you'll still be alive after 6 months. If you're older, the risk of dying from your complications in hospital persists even after the acute period. And so this is obviously very similar data to what we've shown. So how can we select which patients are likely to do badly and which patients are likely to do well? I just want to touch a little bit further on the outcomes. So mortality is one end of the scale, but what you're really aiming for is people to get well and go home. And this, at the Royal Brisbane, the chance of going home is only about 30% once you hit 80, only 50% once you hit 70. And again, this is all comers. And those people who go home are not necessarily great. So from the Italian intensive care group, patients over 60 who survived have about a 50% chance of actually being moderately disabled. And my observation is that even in this green group that are favourable, they're not the same. So they can't do the cryptic crossword anymore. Their wife has to do the tax. They can still play croquet, but they can't play golf because their balance isn't good enough for the swing. And so although these are good outcomes, they're not fantastic. So it's important to be able to educate the patients about the likelihood of this sort of outcome and to find out what they want for in the long term. So the most obvious way to stratify patients to work out who's going to do well and who's going to do poorly is by GCS. So patients who present with a GCS of 10 or 15, so these are the grumbling, confused, maybe obeying, maybe localised patients, they're likely to do okay. The patients who present unconscious are much more likely to do poorly. And overall, one review states that if you're over 80 and present with a GCS of under 6, you've got a 4% chance of going home. Though, as I've said, getting home is not everything. So GCS clearly stratifies patients into patients who are much more likely to die. And then there's other subgroups that can be used to help guide our decision making. The energy impact and the fall, so a high-speed traffic accident versus a low-speed traffic accident versus tripping over your wheelie walker is not the same injury. There's one very important implication of this though. Your patient on the ward with their diverticulitis or their Colles fracture, when they slip and fall on the ward, you are potentially moving them into this group with a 10% mortality. And so you need to watch your ward falls as if they might die, because they might. The type of injury they have is also important. So a simple acute subdural has only a 30% mortality. If there's diffuse injury as well, so subarachnoid and intracerebral, that makes it, the mortality goes up. In patients who've deteriorated to the point that surgery is thought to be a good idea and they get it, their mortality is over 60%. If they don't get it, it's even worse. Similarly, contusions requiring surgery with or without surgery. And overall, various groups demonstrate that if you get an operation, you're likely to do better than if you don't. Now, that could be entirely a selection bias in that the patients who look physiologically well enough get operations and the poor patients don't. But it does challenge a little bit my idea that if you're over 75 and need a craniotomy, you're going to die. So I also pulled all of the patients at the Royal Brisbane who'd had craniotomies for any reason. So these are the patients in their 70s, patients in their 80s, patients in their 90s. And when I've said all trauma, that's the head injuries, trauma requiring a craniotomy, or craniotomy, all craniotomy. So this includes traumas, tumours, all sorts of things. And it's clear that it's not the craniotomy that is the dangerous thing, it's the trauma. And so I think I need to revisit my idea that if you're over 70 and you have a subdural that looks like it needs a craniotomy, you probably deserve the craniotomy. Though the other way of looking at it is if you need a craniotomy, it means your GCS has now dropped far enough that you're into that bad group. Most of these others are episode changes and transferred to other hospitals for rehabilitation. And then the other factor is antithrombotics. We have a sense that aspirin is catastrophic, but that's not actually supported by the literature. There's a little bit of debate about it, but in general, patients with no antithrombotics seem to do similarly to patients on aspirin, on antiplatelet agents. Patients on warfarin seem to do worse, but what was interesting is that these patients had a worse presenting GCS. So it seems that if you're on warfarin and you fall, you're more likely to get a bad injury. But if you arrive at the hospital, say with a GCS of 10 on warfarin, you probably will do similarly to a patient who's not on warfarin with a similar clinical picture. So how do we use all this to help us make decisions? I drew the line at 50% going home. I thought that's probably, you want to know if patients have a better than even chance of getting home. And probably the people in that likely to go home group are those who are under 70, who are alert and have the GCS of better than 10, who are previously fit, so they've got a reasonable amount of reserve and they're not on antithrombotics, so as I've said, that's a bit controversial. And the patients who have a significant risk of not going home are those that are older, are clinically worse, whose scans show that they have a worse diffuse injury, the brain parenchyma is actually damaged. I haven't showed you the data, but the more comorbidities you've got, the more likely you are to get complications and the less likely you are to make a good outcome. Those on anticoagulation, and people who are already supported, because if they go home a little bit worse than they are now, they're probably going to drop to a point that they need to be in a nursing home. And the way I put that to patients is if they're walking independently now, they'll probably go home with a stick. That's the best outcome. If they've already got a stick, they're going to go home with a four-wheel walker. If they're living completely unsupported, they'll probably need Meals on Wheels. If they're already getting Meals on Wheels, then they're going to need to go into residential accommodation. And that's the best possible outcome. That's that little group that they're not the 60% that have died, they're not the 20% that have an unfavourable outcome. They're the good, that's the best thing that people can be aimed for. So how does that work in practice? We have this 89-year-old lady who's slipped on the way to the dining room at her residential village and she's on clopidogrel. She comes in at about 5 p.m. and her GCS is 14. She's a very little bit muddled. And the care is the same as for a younger person with a head injury. But it's really, really important that we start by communicating with the family. So I have a discussion that says you, if it's with the patient, or your husband, wife, mother, has had a head injury and this is bad. Either they'll get better or they'll get worse, and I don't know yet what's going to happen. And then I say, tell me about them. And I want to find out what matters to them and what they like doing with their life. And then I talk to them about the likelihood that they're going to deteriorate. And I often, for example, in this patient, I say, If it gets worse, there is an operation that could be done that's likely to save your life. But when you go home, you're going to have to move back to the nursing home part of your village now. You won't be in your own unit. Do you want us to do that operation? And very often, the patients say, no, I don't. If I'm not going to be as good as I am now, I don't want you to push on. It's harder to get the family to say that, but they can. And then the usual care, so regular neuro-obs, frequently to start with, keep an eye on their sodium. The next day they'll need a speech assessment and may need nasogastric feeding, physiotherapy for their chest and mobilisation, DVT prophylaxis, and chemical prophylaxis is indicated and safe from day one, even in these patients with hemorrhages. And then later they'll need occupational therapy assessments and rehabilitation. Our patient hits the ward, and she's now got a GCS of 6, and this is what her scan looks like. If you've had that earlier conversation with the family, this is seen as the natural history of the condition. If you haven't had a conversation with the family, this is seen as a failure of care. And the way everybody feels about that, the family, the hospital, the lawyers, is very, very different. It's really important to keep talking to the patients. This family said she's still railing at the fact she can't drive anymore. She would not want to go home if she's worse than she is, and so it was clear that we should palliate her. A more problematic case, this is a 70-year-old man who's fallen from his horse and come in with a GCS of 11. There's no operation to do. He's not bad enough to die. All we can do is communicate with the family and look after him. At 12, he has a 34-day admission. He gets a big PE, which has left him in AF. We discharge him to his local hospital, walking 4 metres on a rollator frame with physiotherapy assistant. A year later, he's home. He's fallen into that green good group in the outcomes. But actually, his wife is now spending her entire life looking after him. He's being investigated for normal pressure hydrocephalus because his short-term memory is hopeless. He's needing assistance to walk. It's not a good outcome, even though this is the miracle that's the survival after a significant head injury. So my conclusions are that head injuries are bad, particularly in the elderly. Communicate, communicate, communicate. Assess the patients clinically, and then use that assessment to act in the patient's best interest, considering their age, their injuries on the scan, their comorbidities, their pre-morbid function, and their whether or not they're on antithrombotics, and the patient's desires about what sort of outcome they would think acceptable. And very often, to just maintain their comfort and dignity, we shouldn't aggressively treat these patients. And that's something that the next talk speaker, I hope, will address for us. Because even the miracles are qualified in this age group. So thank you for your attention.